Hi, everybody. This is the class recording for our high-risk newborn. Okay. So when we think about our high-risk newborn, there's a lot of different things that we can consider. And so we can classify them by their gestational age. We can classify them by their weight. We can classify them by any problems that they have. So we can look at if they're preterm, like less than 37 weeks, if they're IUGR or intrauterine growth restricted, and a lot of different things like that. So for our preterm infant is born before 37 weeks gestation. And this is the majority of the babies that end up needing to be in the NICU. They need time for growing, to figure out how to coordinate feedings, how to keep their body temperature up. They have a higher risk of infection. They have a higher prevalence of temperature instability because they don't have as much brown fat that helps keep their body insulated and keeps it warm. They're more susceptible to hypoglycemia, hyperbilirubinemia, and a lot of these kind of things. So these are our babies that we most often see in a NICU. So babies that are preterm, the things that we worry about, one of the big things is breathing. And so babies that are born too soon have less surfactant. And so we have learned before about signs of respiratory distress in our newborn. And those signs and symptoms can be manifested into an actual respiratory distress syndrome when you don't have enough surfactant. So the symptoms are similar to what we've learned. So tachypnea, where the breathing pattern is greater than 30 breaths per minute. Retractions, so intracostal substernal retractions where it sucks in when they're trying to breathe. Nasal flaring, where the nares flare out. Grunting, where they make that sound on breathing out, where they go where they're trying to force air out of the lungs. So we see them trying to work hard to pull air in and to push air out. And so a lot of these, and then color, I guess. So acrocyanosis we know is normal, right? Where the hands and feet can be purplish or bluish, but if they have central cyanosis, then that's a concern as well. So these are the kinds of signs and symptoms we'll see. And with respiratory distress syndrome, it is caused because that they have a deficiency in surfactant. So because of this, we are keeping in mind that we need to help these babies help keep those alveoli open. The surfactant, they don't have as much to do that. So that's where CPAP comes in, or continuous positive airway pressure. And we can see a picture of that on the slide, where we can put this onto babies to help keep those alveoli open. Also, some babies that are preterm can be administered surfactant through an endotracheal tube, and that can also help. We're really careful with the oxygen, oxygenating our preterm babies. We want to keep their saturations greater than 92%, but we don't want to give them too much oxygen, because high exposure to oxygen, high concentrations of oxygen for prolonged periods of time can cause what's called a bronchopulmonary dysplasia. So that's what we can often see for little babies like this that have been needing to be intubated and being on high flow oxygen for a long time. The other things that we worry about for these little babies are things like retinopathy, where they can have permanent blindness. Apnea of prematurity, where we might need to treat them with medications like caffeine to keep them breathing, things like that. Other complications that we're going to think about for our babies that are preterm. Higher prevalence of infection. And so sepsis is a concern. And oftentimes with neonatal sepsis, we don't see signs and symptoms of sepsis the same way you would see in an adult. So oftentimes these babies are cold. So temperature instability. We can see them not feeding well. We can see signs of respiratory distress. We can see signs of hypoglycemia where they're jittery, and these kind of things. So this is a big risk. Risk for cold stress. Cold stress is something, it's a kind of a cascade that can happen when babies get too cold. So since babies cannot shiver to stay warm, their body starts using brown fat and burning it for heat. And that creates this whole cascade that can lead to hypoglycemia, and it causes symptoms like bradycardia. They can be tachypnic, and then have periods of apnea. They can have mottled skin. They have decreased temperature. They can be lethargic. There's a lot of different things that go with this. So, so cold stress is a big concern, and thermal stability is a big concern. So we're trying to always make sure we're keeping our babies warm. Skin to skin is a great place for this. Using a radiant warmer if we don't have them skin to skin is an important consideration as well. And so, or hats, wrapping them with a blanket, things like that. Hypoglycemia. Hypoglycemia is more prevalent in certain babies, pretermers being one of them. We see hypoglycemia also, we learned about it related to babies that are born to diabetic mothers, because that babies are making their own insulin, and mom's glucose is coming in during pregnancy, and then when we clamp the cord, now we're getting less, and so those babies can be hypoglycemic. Also macrosomic babies can be hypoglycemic. There's a lot of times that we can see hypoglycemia. For preterm babies, we're looking at glucose levels that are less than 30. And signs and symptoms are going to be the same as even your term newborn as far as hypoglycemia goes. And so we're seeing tremors, jitteriness, weak cry, lethargy, poor feeding, okay, and temperature instability. So the cold stress and with temperature instability can also cause hypoglycemia. The two can be related. And so if you have a baby that is cold, you should check to see what their blood glucose level is also, because those two can go together. Okay. Hyperbilirubinemia and jaundice is also more prevalent in your preterm baby. Hyperbilirubinemia is when we have too much circulating bilirubin, and babies need to be able to excrete it. And in order to excrete the bilirubin, their body has to be able to break it down. And in order to break it down, we can do things like phototherapy to help the body break down the bilirubin for excretion. And then we want to get those babies eating so that their body is excreting the bilirubin through the feces. Necrotizing enterocolitis. This is something that we can see in preterm babies. This is the most common time we see it. It can progress to perforation of the bowel, so we can see grossly bloody stools, abdominal distension, and the best way to lower the prevalence of necrotizing enterocolitis is with breast milk. So here's our bilirubin when we're thinking about hyperbilirubinemia. So it's excreted in the feces. The bilirubin needs to be broken down, like we just said. So if it's what's circulating in the baby's body is an unconjugated bilirubin, and they think about it like a big chunk. And we need it to be broken down or conjugated in a way so that the baby can excrete it. So Billy lights or phototherapy is the main way to do this. And so there's a lot of things we think about with phototherapy. We want the skin to be exposed. It's like a blue light or UV light. So the eyes need to be protected. So we put a little covering over their eyes, and then they have a diaper on only, and then everything else is exposed under the light. And this helps their body break down that bilirubin. If we don't do a good job, if their bilirubin levels become too high, they can develop kernicterus, where the bilirubin builds up in their brain, and it can be catastrophic. Okay, so typically what we see a yellowing of the skin and of the sclera. with because of these babies develop jaundice because of their high levels of bilirubin that are circulating. Breastfeeding is going to be important. If they are breastfeeding, it's going to be important to be doing lots of frequent feedings. In addition to this, we are going to be monitoring their intake and output. We're monitoring for signs that they can be developing encephalopathy. So hypotonia, seizure activity, things like that. For our newborn, our goals are going to be feeding, growing, breathing, temperature regulation. So for thermal regulation, depending on how young they are, oftentimes they are in either an incubator or a place that has a heat source. Okay, until their body is able to regulate their temperature better on their own. Skin to skin is still the best place. And so we'll do a lot of kangaroo care with these kids where we're getting them on mom and or dad. If they are needing gavage feedings, oftentimes preterm babies are tired and they can't coordinate, suck, breathe, and swallow and do a good job of getting all of their calories. So we might do gavage feedings where there's a tube that goes down into their stomach, and then we let the feeding run through syringe to gravity. And so when we do gavage feedings, we are going to first aspirate stomach contents. If their stomach contents to be aspirated, then we want to let the provider know beforehand, before we do the feed, and determine if there's anything, if we want to wait or whatever. And then we're also monitoring their meconium and watching to make sure that they're stooling and that it's transitioning to a newborn stool and those things. We're also thinking about for these babies position, so that number one, we're changing their positions frequently so that they don't have skin breakdown. And number two, we also want to position them in such a way that it promotes their respiratory effort. And you can see this little pumpkin again has his CPAP on. For discharge teaching and planning for your preterm baby, a lot of the teaching is similar to our well babies in that we're wanting to help those parents learn CPR before their baby goes home. We want them to know how to arrange their pediatrician appointments, what immunization schedule the child's on, infection prevention. Hand washing is the best way to prevent infection, both in the NICU and at home. So we're teaching hand hygiene, car seat safety, being on their backs to sleep, things like that. We want to really work with these parents on demonstrating. So doing a teach back method and having them demonstrate cares, especially if their baby's going home with things that they need to be able to know how to manage. All right, next is post-term. So our post-term babies are past 42 weeks. And so a few things happen when the baby stays in utero past to 42 weeks plus. The placenta is often not working as well at this point because the placenta is really only meant to grow the baby, and then it starts developing calcifications and things like that. Babies that are past their due date can have a higher prevalence of releasing meconium, and so they can have meconium aspiration, where they can develop pneumonia. Their skin is usually drier, maybe cracking and peeling. They have a higher incidence of hypoglycemia, higher risk of birth injuries if they have grown too big or if they're microsomic. They can feel distress. There's a lot of different things. So in labor, we're watching that labor closely and watching for signs of distress in labor, and then being prepared for some of those things at delivery and monitoring that. Okay, next topic is perinatal injury and congenital malformation. So there's different birth defects that we consider, different malformations, different congenital things. And some of those we're going to talk about. There's a lot, but there's a few that we are going to pay special attention to. So neurotube defects is one. So neurotube defects is going to be when you have the neurotube doesn't close. And this usually happens around week 9 when they're during the pregnancy. And so by the time that we know that it's a problem, even with good prenatal care, we've missed our window. The biggest way to prevent neural tube defects is going to be folic acid. And if they're taking folic acid before they get pregnant and then in the early part of pregnancy, that's going to help the most for this. If this happens that they have a neural tube defect, then depending on the severity is going to depend on how we treat that baby at delivery. Okay, so we're going to look at that a little closer, and we're going to look at hydrocephalus. Hydrocephalus is something that is, we'll learn how to look at it on a different slide. It affects the way that the cerebrospinal fluid is draining from the ventricles of the brain, so the head can become very large. So here's your spina bifida baby. So you can see a lot of variations of a neural tube defect. So for some, we can see what's called a sacral dimple, where when you look just right at the sacrum, you can see an indentation. And if you separate the tissue, it's either closed at the end or it isn't. If it's closed at the end, then that's obviously better. And if it's open, then we need to notify provider and they need to look at what needs to happen in order to help repair that. If you have a baby that has something like this, where you have a myelomeningeal, where part of the meninges are actually outpouching from the back, then you're going to need to do like this little pumpkin on the top right, where you put sterile gauze with moistened saline over this and keep it covered until it can be surgically repaired. Hydrocephalus. So with hydrocephalus, you, as I had just said, you have a decreased drainage from the ventricles of the brain. And so it causes a buildup of intracranial pressure. And so it looks kind of like, you can see the difference in these two pictures here. And so the head becomes more and more enlarged. And so we'll see things like the head is growing larger, the fontanelle might be bulging up because of the increase in cranial pressure. We are needing to support the head really well, especially during feedings. We're measuring the head to see if it's continuing to grow larger still. And these babies are often have a surgery where they put a shunt in that helps that cerebrospinal fluid drain down into the bodies to release the pressure from the head. So for nurses, we are doing teaching to the parents. We are monitoring for any changes in level of consciousness and things like that. We're measuring the head. We're protecting from infection. And we're supporting the head well. Signs of intracranial pressure increasing. So this could be something like your hydrocephalus baby. Also, things that can cause increased cranial pressure could be things like abuse, like people that shake their babies and different things like that. So what we'll see oftentimes is a high-pitched cry, bulging fontanelle. We might be able to also notice changes in the pupil size and head pain and headaches. Down syndrome. Down syndrome is our most common chromosomal abnormality. This is something that we often see. It's more prevalent with moms that are more than 35 years old when they get pregnant. We test for it. So when we do the alpha-fetoprotein during pregnancy, if the score is high, that can be a sign of a neural tube defect. If the score is low, that can be a sign of deficit. We can diagnose Down syndrome with an amniocentesis. And so that would be one time that an amniocentesis might be done to diagnose it. Babies that have Down syndrome have very distinct features. So they have the closed set eyes, the protruding tongue. You can look at the hand and look for a single simian crease. That's something that we can see. The big toe and the smaller toes have a gap between them. There's a few other things that are distinctive characteristics that we see physically. These babies have a higher prevalence of heart problems. They also can have some mild to severe mental retardation, and they're more prone to infections. Cleft lip and cleft palate. The lip is the pictures on the top, and then the palate is the picture on the bottom. How we manage this, it can be a surgical procedure to repair, but it's going to depend on when we do it, depends on how severe it is, I guess is what I'm trying to say. So we will want to try to repair them by 3 months of age, and the more severe should be done as soon as possible because it can affect feeding. They might need special syringes or bottles to help make sure that they're getting the hydration they need. It's difficult for babies, especially with the cleft palate, like the one on the bottom, to form a good seal for breastfeeding. And these babies have a higher prevalence of ear infections, in addition to having difficulties with feeding. So nutrition is a big concern, and then monitoring for infection. Once a baby has their cleft lip or palate repaired, then we will teach parents how to use a dropper for feedings until the wound is healed. They can still eat breast milk or formula, and so we're just going to teach them also how to keep the area clean, and how to prop an infant when they're feeding. Clubfoot. So this is one of the most common deformities. This is a congenital anomaly. Oftentimes it is easily fixed with casting or physical therapy. Sometimes in severe cases, it may require surgery. So if they have surgery, then we're going to be, again, teaching signs and symptoms of infection. We're providing emotional support. If they're doing casting or splinting, then we also are helping teach how to take care of that. Physical therapy we will be reinforcing the beneficial associated. Hip dysplasia. So hip dysplasia is going to be something that affects the hips, where they can either be subluxated or dislocated, depending on the severity. So the head of the femur is either partially or completely displaced. It happens more prevalent for girls than boys. And what we see on assessment is we can see where the gluteal folds can be uneven, so asymmetrical. And if we have asymmetrical gluteal folds, the other thing I'll look at is I'll bend the knees up and I'll look to see if they're even. And then I'll pull the legs straight and look to see if they're even. There is a test that you probably see. I don't know if I can demonstrate it very well in here, but they bend the knees up and then they roll out. This is the Barlow and Ortonelli sign, where you can check and feel for a click. This is something we're getting away from in practice because it can actually dislocate and then relocate the hip. And so I'm looking for good range of motion. I'm not doing the Barlow and Ortonelli. So if a baby has hip dysplasia, then they're going to be in special splinting that keeps the hips flexed and abducted, and to keep the femur in the hip socket. And then sometimes these babies need surgery. Metabolic defects. So these are errors in metabolism that can have similar signs and symptoms, but they're caused by different things. So signs and symptoms for any of these are going to be hypotonia, where they don't have good muscle tone, tachypnea, so fast breathing. They can be lethargic, have poor feeding. Sometimes there's different odors that we notice. So Galactosemia is an inability to use galactulose. Okay, so these babies cannot have cow's milk or anything made with cow's milk. It can cause cirrhosis of the liver. These babies typically aren't breastfed because moms would have to cut out every single bit of lactose from their diet. So they're on very specific diets. PKU. So PKU is phenylketonuria, or phenylalanine. That's why it's called PKU. So these babies are not able to appropriately metabolize phenylalanine. And so for this, we test babies for it. It's part of the metabolic screening that happens in the first after 24 hours of birth, and then they do it again in 2 weeks, where they put blood on 4 little circles on a card, and it gets sent to a lab that checks for it. If the baby if they have PKU, they cannot eat foods that are high in phenylalanine, so they are on a special diet, and there's a lot of genetic testing that goes with that. Maple syrup urine disease. This one, it starts out where they notice that the baby has a sweet smell. Their blood glucose level is normal, but they are emitting a sweet odor. This actually can be a pretty big problem that can result in acidosis if it's not treated, or even these babies could die. So they'll have normal vital signs, they'll have normal glucose levels, but they'll have the sweet smell. And so they are often on dialysis and things like that. Hemolytic disorder. So this is when we think about blood incompatibility. And so this has been something that we should have discussed before now in relation to the mom being Rh negative and the baby being Rh positive. And so we've talked about how that from the mom's perspective, but here's what happens from the baby's perspective. If mom's Rh is negative and baby's Rh is positive, mom should have gotten RhoGAM at 28 weeks gestation, and then at birth, when they determine the baby's Rh is positive, mom will get another dose of RhoGAM. That is going to prevent her body from developing antibodies that can attack another baby with future pregnancy if they are also Rh positive. If that didn't happen, so that this is the second baby, and the first baby was Rh positive and mom didn't get RhoGAM, the second baby could have the problem. And so the mom's antibodies that could have built up can cross through to the baby and attack the red blood cells and break them down. And so it causes hemolytic disease in the newborn, which is erythroblastosis fetalis. These babies sometimes even need exchange transfusions before they're even born. And they are babies that can have severe hyperbilirubinemia in the first 24 hours of life. And so it can be a really big deal. For ABO incompatibility, this is when mom's blood type is O and baby is AB. And so with this one, this is not dependent upon what happened with the previous pregnancy or anything else. So if the mom's body is sensitized and has antibodies for anything other than O, it can cross through and it can break down the baby's on the current pregnancy. So these babies also then you see hyperbilirubinemia and anemia. So these babies, so we test all babies actually for hyperbilirubinemia. We do bilirubin checks, but these babies, if we know that there is either a setup, we can do a direct Coombs and an indirect Coombs to see if mom's blood type is O. If the baby's red blood cells have antibodies on them from mom, then we are watching those with this concern. Drug exposed infants. So these are babies that where the mom has been taking illicit drugs during pregnancy. And so all of these drugs do cross over the placenta and they do expose the baby, and the baby does become addicted. And so anytime that this is the case, these babies are at risk of having withdrawal. And so if we know that mom has a drug use problem, we will encourage her to be on a program with methadone to try to get off of the illicit substances, but babies will also withdraw from methadone as well. Moms, if they're taking methadone or Suboxone and not taking the other drugs anymore, they can still breastfeed. If they are using drugs, they shouldn't. Okay. And so how the baby withdraws is going to depend on how much exposure they had and how recently it's been. So signs of neonatal abstinence syndrome or newborn withdrawal. There's a lot of signs because it affects a lot of their organ systems, but the big things are going to be high-pitched cry, seizures, fragmented sleep, poor feeding. Oftentimes we see a lot of yawning, a lot of sneezing. They can be tachypnic, diaphoretic, mottled skin, temperature instability. And the main thing for these babies is going to be to swaddle them and keep them in a calm and quiet place to help minimize their stimulation. So you think about all of these signs we're talking about is all hyper, right? Hyper irritability and tremors and all that, high-pitched cry and everything's like this. And we got to just bring it down and keep them very calm and very safe and very snuggled. Okay. Baby is born to diabetic moms. So I mentioned this in relation to hypoglycemia earlier. So babies that are born to diabetic moms, they can be bigger or macrosomic. If you have a baby that is born macrosomic, macrosomia is going to be, after they're born, we call them large for gestational age or greater than the 90th percentile. So if you have a baby that's LGA or large for gestational age, I'd go back and see was mom diabetic? Did she have gestational diabetes? Sometimes that's not even undiagnosed. If you have a baby that's macrosomic, they have a higher risk of hypoglycemia. So they should be fed frequently and often. They also have a risk of birth injuries being larger. So that baby might have had a risk of like a shoulder dystocia. They have these babies also very interestingly can have respiratory distress syndrome. So we talked about that in a lot of detail at the beginning of this because we were talking about it in relation to your preterm baby. And that is the time that we usually see a surfactant deficiency is in preterm babies. However, your babies that are born to diabetic moms, if there's been poor glycemic control, these babies can also have a surfactant deficiency because their body is making its own insulin and it's making lots and lots and lots to combat the high levels of glucose they're getting from mom. And so that increase in insulin production decreases their surfactant production. So sometimes you can have a big chunky baby that is having difficulty breathing and breathes like a pretermer. So we can also see signs of respiratory distress. So for babies that are born to diabetic moms, we're assessing for anomalies. If the mom was diabetic before she got pregnant, that baby has a higher risk of congenital anomalies. If she developed gestational diabetes during her pregnancy, that baby won't have the same risks because all the organ systems were formed before she developed diabetes. We're going to look for birth injuries in case there was a shoulder dystocia. The baby's macrosomic. We're monitoring glucose levels because the baby has a higher prevalence of hypoglycemia. And then we're also making sure that this baby's staying warm and we're working on thermal regulation. Meconium aspiration syndrome. This happens when the baby breathes in amniotic fluid that has meconium in it. So if the baby passed meconium in utero and the meconium fluid goes into the lungs, then it actually then creates a pneumonia for the baby. And so what we see after delivery is we can see signs and symptoms of respiratory distress. So all the things we talked about with respiratory distress earlier with our preterm babies, those are the same signs we can see from meconium aspiration syndrome. So we can see tachypnea, breathing faster than 60 breaths per minute. We can see grunting, nasal flaring, retractions, things like that. Okay. So for birth trauma is an injury that's sustained during birth. These are often avoidable if I know that mom is diabetic with poor glycemic control and the baby's macrosomic, maybe she should have a C-section. Okay, if we're not sure that the baby's going to fit. Things like that. But some things we don't even realize and we don't know until birth that it's even an issue. A clavicle fracture is the most common birth injury. It's most often caused by the shoulder dystocia. And so we can feel when we palpate, we're doing a head to toe assessment on a baby. I just feel where the clavicles are. I feel for crepitus. And then when I check reflexes and I elicit the Moro reflex or the startle reflex, I look to see if it's even. If it's an uneven response, I'm worried that this arm is compromised, probably by a clavicle fracture. If this side doesn't move at all, if the affected side does not move even a little bit, then we're worried about a brachial plexus injury, which is a bigger problem with the stretching of the nerves. And that often can happen also with a shoulder dystocia. So those are the big things that we're thinking about with birth trauma is the shoulder dystocia and how that affects either for brachial plexus injury or for a fracture. Okay. For intracranial hemorrhage, there's different things we could see for this. This can also be a result of trauma. It could be because they were preterm and they have these tiny little vessels in their brains that can break. There's things that we do, like we give vitamin K injection to all babies to help reduce the risk of vitamin K deficiency bleeding. But the other things that we're considering is preterm babies, precipitous labors, birth trauma. We can see it not commonly, but we can see it sometimes with like forceps and vacuum assisted deliveries, things like that. So signs and symptoms: hypotonia, lethargy, poor feeding, respiratory distress. You can see that a lot of these have similar signs to other things we've talked about. Okay. Also that high-pitched shrill cry and seizures. And that is the extent of our high-risk newborn lecture. And I hope you have a great day.